As you can see, this is a lecture that Emily was meant to give, but she unfortunately sort of come down with a cold, so I'm going to fill in for her. Hopefully I'll get across all her ideas without too many stumbles, but the focus of this presentation is the practical side of doing economic evaluation, particularly alongside clinical trials, is where a lot of the work that us in particular at the George Institute get involved in. So we work with colleagues who do clinical trials and routinely build in to the clinical trials economic evaluations. But when I say clinical trials, I think a lot of the issues here, they apply not just to clinical studies, they also apply to more pragmatic impact evaluations in public health, health policy, etc. Before I get into this, Verge reminded me of an important point following on from the previous session, the CHEERS checklist. It's ostensibly to sort of enable us to, appraise the presentation of economic evaluations, but it can be really a useful tool for helping us to plan economic evaluations as well. And that's something to bear in mind, that it is something when you are working on developing an economic evaluation, it's well worth keeping that as a reference point for your. Having said that, there are also other resources that are available, and you would have seen that in the reading list in your the agenda for this course. A few of those resources we were involved in publishing with New South Wales Health. I know Cher's also been involved in developing some resources in economic evaluation as well. So please use those if you think they're useful. Okay, so economic evaluation alongside clinical trials. So these are the objectives of this session. Firstly, identify when economic evaluation alongside trials is useful. I would argue probably in 99.9% of cases. Consider the relevant perspective for the decision maker. So again, that's probably related to a broader question, is what is the policy question? What's the investment decision that we're trying to inform? The thirdly is identifying methods for collecting costs and outcomes. I know Joe and Rebecca touched on a lot of those, but we can, what I think Emily's done is identify very specifically the sort of resources that we can use to gather cost and outcome data. And then finally, describe when modelling may be beneficial. So I'm not going to go into too much detail here about how you do modelling. Modelling is a whole can of worms and involves, years of training. But what is important for you to know is what role it plays in an economic evaluation, particularly how it augments the evidence that you're collecting in your empirical study, enabling you to extrapolate some of the outcomes that you're getting from your research to outcomes that might be relevant to a decision maker. So, like in the study that David was presenting last session, the 20-year outcomes in terms of the impact of male circumcision, not just on outcomes, but also long-term costs. And that's where modelling comes into its own in economic evaluation. Okay, any questions about those objectives? You okay with that? Okay. So the first question Emily poses, do I need to consider an economic evaluation? And she's given us an emphatic yes, and I agree. I think at least consider it. It may not always be appropriate, but I would say most of the time it will be. And most of the time you build it in, and not most of the time, a large proportion of the times, you'll find at the end of the study you won't need it. That's particularly in the cases where you find that your trial's not come up with an effect of your intervention. So if it's not effective, it's not going to be cost effective. That's sort of a fact of life. So it doesn't mean you don't do anything. You've collected a lot of cost data. You've collected potential quality of life, and we try to sort of salvage that we've published information around the costs associated with various sort of patient populations. We've looked at quality of life and that sort of thing. So it means that you still use that information and provide some important data to decision makers, even if you're not necessarily proceeding with the cost effectiveness analysis. The other point that she's got there is that you need to start early. You need to plan in the project planning phase. I've spoken to a few people here today who said that they've the experience has been that the economic evaluation has been sort of thought about midway through the study, and they say, well, the problem there is that some of the opportunities to collect the right data have been lost. You need to prospectively collect a lot of the data that we need, particularly around costs. We also need to budget, pragmatic level. We need to budget for the economic evaluation. We need to staff it. And if you apply for a grant just for the trial and no economic evaluation, unfortunately, I can't help you. We can't work for free. And so we need to appropriately sort of think about these things early on so that we can build them into a grant budget. We need to consider the question of why. We do trials to improve care. This care is delivered in a space with constrained resources. Generating evidence to support implementation or not can help guide decision makers. It's not needed for consumer products. Example, Fitbit. Each individual decides for themselves if they think it's worth the cost. So essentially, it's that point that we talked about earlier, right at the first session. It's around helping government make decisions about allocation of resources in the absence of a market-based mechanism to decide on that. And obviously, it's based on costs and benefits of the program. So the next aspect of an economic evaluation is perspective. So what kind of intervention, where, who would decide if it is implemented? And this helps you decide what costs and outcomes you need to collect and how. So the perspective, as I said earlier, really is based on what's the underlying policy and investment decision that you're trying to address. Is it state government? If it's just state government wanting to know whether the new model of care is cost effective, and they're only interested in costs to the state health department, then that's the perspective you adopt. So from that point of view, you won't necessarily need to collect Medicare data in order to look at the costs to Medicare. The problem with that, doing that sort of work, and this is sort of work we get involved in quite a bit, we do a lot of work with state government, is that what it means is that it's often then difficult to discern whether the program is genuinely cost-saving or whether a lot of the cost savings that you're observing are really just shifting costs onto Commonwealth, onto Medicare system. For instance, you have a program that keeps people out of emergency departments. Emergency departments is often seen as a big source of leakage in terms of state government resources and unnecessary expenditure. So they're always talking about programs that try to keep people out of presenting at EDs, but a lot of that involves sort of channeling them into primary care. So fine, you're saving New South Wales government a lot of money by keeping people out of EDs, but potentially you're increasing Commonwealth expenditure. From the funders' perspective, they don't care. They're just interested in the New South Wales budget. So from an evaluator's point of view, I do think it is important to, even if you're being commissioned by New South Wales, to be able to distinguish between a genuinely cost-saving program from one that is, to a certain extent, shifting costs onto other sectors or onto families and patients. Okay. Power and sample size, and that often comes up when we're discussing the design of an economic evaluation with clinicians. They're often obsessed with sample size, rightly so, because I think their ability to get a grant funded for a trial will revolve around the credibility of their power calculations and their ability to recruit patients at a level which they've specified in their statistical estimates. Power and sample size for economic evaluations is a bit of a grey area. There are ways in which you can calculate sample size and often means, and as this is a point that Emily says, powering for joint distribution of costs and effects usually requires larger samples and longer follow-ups. So it often means that if you really wanted to power your trial to measure the cost effectiveness, that you're going to need a bigger study. You need a bigger budget and bigger trial. And that's not going to happen. I mean, basically, most trials get funded to enable them to achieve the clinical endpoints and power to measure the clinical endpoints. So we have to be pragmatic. And health economists have developed analytical techniques that enable you to generate estimates that that get around the issue of the underpowering of trials. So there's a point there that Emily raises on the last bullet point, EVPI. So that's expected value of perfect information. That's a tool that people have talked about to use to inform the design and powering of trials based on this idea that we need to achieve enough power to get perfect information in terms of cost effectiveness as well. My sense is that this is an area that's generated a lot of health economics publications, but really my understanding is that they're very rarely ever implemented in real life. As I said, we often in real life, when we're designing studies, we power for clinical or the public health or the main primary outcome, and that's basically where we end, and we make do with the cost and effectiveness information that we can within those parameters. So costing information. So that's so on a pragmatic level, there are a number of areas where we need to measure costs for an economic evaluation. The first aspect of a cost calculation are the intervention costs. So how much does it cost to actually run the program or pay for the medicine? So that's the direct cost of the intervention itself. And so the sources of information we need for those intervention costs are things like financial statements from the various health facilities that are involved in running the program to ascertain things like staff costs, consumables, equipment, rent, those sorts of things. And we can also conduct interviews and time and motion studies to get a handle on those costs. But we also need to bear in mind the point raised by Verge earlier that there's a certain limit to how far you want to go with doing this. You could sit down and do these time and motion studies, spend 6 months of your life just sitting in a clinic counting how many times people come and forth and see patients. But is it really going to make an impact on your economic evaluation? And if not, then ballpark figures are probably fine. And you can then do a bit of sensitivity analysis around that to cover yourself. The other aspect of an economic evaluation that perhaps requires a bit more attention in terms of the design phase are the downstream costs. So looking at the healthcare use of participants in your study over the duration of the study. So it might be a 2-year study. You might have a trial where you have patients in a standard care arm and patients in a intervention arm. You follow them up over 2 years, and what you need to do is measure their healthcare use over the 2 years. That means hospitalisations, primary care visits, medications, allied health, and see whether there's a cost difference between the two. In an ideal world, you'll find that in your intervention group, you might have lower downstream costs because of improvements in health results in cost savings, or cost offsets. That's the term that we often use, cost offsets in based on these reductions in these downstream costs. There are a number of ways in which you can measure these downstream costs. The most basic way is just to include questions in your case report forms. So in your study, you will be following up your participants on case report forms. You're measuring things like your primary and secondary outcomes. You can just add a few questions about costs. The problem with that is that self-reported costs, particularly recalled retrospectively, and particularly if it's over a long time, are notoriously unreliable. People have they might remember the hospitalisation they had 6 weeks ago, but they have a lot of difficulties, particularly if you're talking about people with chronic diseases, remembering other items of healthcare use. So one step up from that are diaries. Sometimes what we do is employ diaries, get people to fill in diaries as they go, and then get them to report that. And that is that gets around the idea of a recall bias, but you also have issues around reliability and people's ability to fill in diaries. And often in low resource settings, they're the sorts of tools that we are forced to rely on. But in high income settings like Australia, we can use electronically recorded data. So linked data, hospitals, MBS and PBS utilisations is basically the norm now with economic evaluation. And as Rebecca said, there's a really important process at the start of studies to consent people to those linkages. Yes?
In terms of linkages,
yep.
Talking through that public versus private,
yeah.
Going to get follow-up, for example,
yep.
How do you manage, what's the best approach to manage that?
Yeah, look, that's a really difficult area, getting private healthcare follow-up usage. You can potentially, I guess, see if you can get to private insurance data, but there's more than one private insurer around, so we tend to just sort of ignore the problem. Really, if you're taking a health sector perspective, it's also debatable whether government is that much interested in the costs to the private sector. If it was part of the question that you're trying to address, then you could potentially, in the absence of private healthcare data, you might be able to impute that based on the patterns of utilisation that you observe in the public system, how many patients that you've got in who might be privately insured, and then you can maybe try to impute those sorts of cost savings. But yeah, it's a difficult one. The ideal world, you'd link to private healthcare utilisation. Have you come across that problem, Rich? Oh.
I'm so used to just speaking.
Just firing straight out of it.
Yeah, it's a really important. It can be a really important area to look at, but as Steve mentioned, getting these data relies on having a good relationship with the private health insurers so that you can actually access their records. The administrative data sets, the national administrative data sets, don't collect those data. They do reflect some use by private patients, but we don't know typically don't know the insurance status of those patients. There are some of the larger cohort databases that have survey information about insurance status that you can start to use to look at differences between public and privately funded or covered patients. But again, it hasn't got that granular information that you would get in the insurance data sets.
Have you had any experience, Virg, with private sector? No. No need to go. So you'll walk. Okay, thanks. And just here's an example, a couple of examples of these are the sort of manually collected data instruments that we've used in the past in some of our studies. So this is a question that's been put into a case report form, I guess. So health service utilisation, you can see it's fairly sort of straightforward. Although for the average sort of patient, it may be pretty difficult to sort of answer this reliably. Similar sort of questionnaire, past 2 months, sort of services that you've used. Yeah, another diary that we've used in the past. Okay, so in terms of outcome side, there are a number of types of outcomes that we can potentially measure. In a trial, it's very rare that we are in a position where we can just look at the trial outcomes and say, fantastic, that they're the outcomes that we want for the economic evaluation. Often the outcomes that we're powered to measure within the time frame of the trial may not necessarily reflect what we necessarily need in the economic evaluation. So in the trial, we typically measure outcomes in natural units, things like blood pressure targets, number of people achieving blood pressure targets. If it was a big trial, we might be able to measure strokes prevented or lives saved. We routinely collect quality data. Usually, I guess the most commonly used instrument is the EQ5D. You might recall Joe sort of mentioning some of the instruments that are available. Most commonly used is the EQ5D. I believe in the UK, the UK NICE, they mandate that it's used for HTA. There's no such sort of mandate in Australia. People are generally free to use, but it's most common. The problem with the EQ5D is it is, well, the advantage of the EQ5D, it's very simple. It's only 5 items, but because of that, it's quite inflexible, and so it's not very sensitive to changes in, particularly in mild health states. But you can use the EQ5D. What we find, I do a lot of trials in cardiovascular disease, particularly prevention of cardiovascular disease, and the endpoints of those trials tend to be reductions in risk of disease. So things like reduction in blood pressure, lipids, behavioural change. And in those studies, we also measure quality of life. And it's almost unnecessary to measure quality of life because for preventative type trials, at the end of the study, you're going to have a very small number of people who actually experience an event. So you're really still at the end of the trial, you still ostensibly have 2 populations who are almost same in terms of health status. One might have slightly better, or you hope, have a better risk profile in terms of cardiovascular risk. So they might have lower blood pressure, they might have better cholesterol and that sort of thing, but that's not going to be reflected in their quality of life. So it's not usually that important to collect quality of life, although we still do it routinely. And that's where the modelling comes in, and I'll talk about that in a sec. So when you've got the trial, that you've got your endpoints, reductions in cardiovascular risk, what you want to do is then extrapolate, and see, well, what happens in 10, 15, 20 years in terms of disease events, quality of life, survival, that sort of thing. So type of outcomes, service output. Yeah, so sometimes the studies themselves aren't even in a position to measure some of these health outcomes. Sometimes they're just service-based outcomes. So things like time to a first appointment, number of assessments completed, number of reports reviewed. And that then makes it quite difficult to do an economic evaluation that, particularly if you want to frame it around a quality or whatever. Doesn't make it impossible, but particularly, and the key here is if there's evidence in the literature that links these outcomes to a long-term impact in terms of quality of life, survival. If there's no evidence in the literature, then you're stuffed. Why use time to first appointment as an endpoint in your trial if there's no evidence to support its clinical relevance, So you really do need good evidence to enable you to link that to a long-term outcome, and then you can use that evidence in your modelling to leverage that outcome. Monetary units, so that's the cost-benefit question. If it's relevant to look at some of the impacts in terms of a benefit in monetary terms, and we don't do that very often, but sometimes we might want to measure the outcomes in monetary units. For instance, if it's keeping people in employment, it's improving productivity, then we can measure that in terms of the dollars that the gain to the economy, and then we can do a cost-benefit analysis. There's still a lot of resistance to doing cost-benefit analysis in the health sector, and I can understand why. There's a certain degree of arbitrariness in terms of, if you think about the value of statistical life that Joe put up, it's a big number, and you're just throwing that on top of a whole lot of clinical evidence and then multiplying it out, and you come up with this this value of life saved. And there's a lot of healthy skepticism about that when you put that in the context of an economic evaluation. Having said that, it's becoming more and more required part of the policy-making process. New South Wales government now makes it mandatory for investments over $10 million and all recurrent investments, particularly in public health, to undergo a cost-benefit analysis. So that means the valuation of the benefit in monetary terms. So it is an area we have to move into and be comfortable with doing. So when we're thinking about the outcomes of interest, we also need to think about the outcomes to who? To patients and families, to clinicians, to decision makers. And that frames the perspective of what we're doing. We're also thinking about not just single outcomes, but multiple outcomes, and how do you measure them? So do you measure them in natural units? So, or ideally, you can try to frame it all into a cost per quality framework, and that's the ideal, that you do your economic evaluation and you come up with an incremental cost per quality, and then the decision maker looks at that and says, okay, is it below or above the line? If it's below the line, let's fund it. And that's the ideal. But in many instances, particularly in public health, we can't necessarily encapsulate everything that we're achieving in the program in a quality. So a lot of public health, a lot of prevention activities, they're about achieving a lot more than just the quality. They're about, improving sort of community networks, boosting social capital, increasing community autonomy, all those sorts of things that you might think are involved in sort of population-based programs. They're not necessarily captured in the quality. So we do have to be a bit careful about just trying to shoehorn everything into a quality measure, and be aware that certain types of programs, particularly public health, particularly disease prevention programs, if you're just using a very narrow quality approach, you're potentially not capturing all their value, and particularly when you're comparing them against the investment case for more clinically focused interventions. Okay. So, in terms of some of the practical issues about sort of planning the economic evaluation, I think the point here is plan from the start. That's really important, and we've already sort of gone into that about budgeting, writing the protocol, building it into the original grant application, having the consents, case report forms all designed so that we've got the appropriate data capture mechanisms in place. Planning visit schedules, length of visits between different follow-ups. The one thing about cost data is that because of the difficulties with recall, you can't leave for 6 months for people to sort of remember, utilise that. You do need to rely on regular sort of follow-up visits. And data linkage, as I said. So, and potentially now we've got capabilities that enable us to link not just to the standard sort of healthcare utilisation data, so New South Wales hospital data, MBS, PBS are the sort of usual suspects, but there are a whole range of other data sets we can potentially link to if it's relevant to our evaluation. So hospital, ambulance, births and deaths, MBS, PBS, education, justice and housing are others. One important facility that you need to perhaps use sometime is Cheryl, the Centre for Health Records Linkage. Yeah, health records linkage, something like that. Anyways, Cheryl, and you can use, and they have a facility to link across multiple data sets in New South Wales at the moment. One of the difficulties is that a lot of these data sets are state specific. If you've got an international trial, which we often get involved in, it's just a pain because you then have to get separate linkages across different states, which can make it a really difficult process. So sometimes you have to make a pragmatic decision about what's important and relevant. Again, back to Virg's point, it may well impact slightly on education and justice, but is it really worth the effort of going through the linkage process to perhaps collect data that may not end up making a difference? And when do you think the effect of the intervention will impact on service use? So again, that's how long do you collect that data for? Okay, so there's just some of the sort of background points. Here, Emily's now given us an example of a study that she led a couple of years ago. It's called the Quartet trial. It's a quad pill for cardiovascular disease, so it's a 4-in-1 pill to reduce blood pressure, I think cholesterol as well, and it's really something that's comes on the back of global initiatives to improve adherence to cardiovascular medicine. I think that the data generally shows that people's adherence for cardiovascular falls off pretty dramatically after the first 6 months. I can't remember, but I think it's around 50% by the time you, for people, risk of cardio, and for drugs that have been proven time and again to be quite effective and pretty low cost. So one of the ways in which people have tried to get around this issue is develop a 4-in-1 pill. So that has the advantage in terms of convenience, but also cost. So there's just one sort of pill rather than paying for 4. And this was a cost-effectiveness study that was done alongside a Quartet trial. So in the Quartet study, there was a brief description of the cost-effectiveness in the protocol itself for the trial. There's a plan for short-term data collection and resource use at 6 and 12 weeks using case report forms. There was major events, so unplanned admissions are captured in SAE, so a serious adverse event form, reporting, and planned data linkage, MBS and PBS for longer term. So there were dates, there were consents for that as well. It's not clear here where the, sorry, I wasn't involved in this, so it's not clear where the hospitalisation data, I guess that was collected through the case report forms rather than through data linkage. So challenges, so timing and funding. So Emily did this through her fellowship. So fellowship funding to do the CEA began and ended while the trial was still recruiting. So that's difficult. Usually the economic evaluation gets done after the trial's completed. So collecting hard copy of DHS consent forms during a pandemic, and database functions and exportable data. Not sure what that means, but I'm sure it's important. Okay, so the trial results, the Quartet within trial results. The trial primary outcome was a change in systolic blood pressure, which is a gold standard for blood pressure trial. So here's a quote from the findings of the trial. So the within trial analysis showed no clear difference in cost per millimeters of mercury blood pressure lowering between randomised treatments at 3 months for quad pill versus monotherapy. So there's no clear difference. So to me, that's the end of story. But obviously there was a bit of a signal in some of the outcomes that prompted her to continue looking and do a modelled economic evaluation. I'll have to ask her what that was. So moving beyond the trial. So actually there's a bit of a clue here. So RCTs have a fixed duration and limited scope. Great for answering questions, does this work? So when looking at whether something is cost effective in a population, we need a bigger picture. That's where the modelling comes into help. So they did a modelled cost effectiveness analysis. So different types of models that are available. So one way of modelling improvements in cardiovascular risk factors is just to simply use a risk equation. So the most obvious risk equation that you can use in cardiovascular disease is the Framingham. So you just plug in the changes in risk factors and that will give you a 5-year predicted improvement in risk of cardiovascular events and death. That's a simple approach. A more complex approach might be using a Markov model, which looks at annual transitions across different health states. So you have different health states and you model somebody, an individual or a cohort's progression through that health states based on evidence from the literature to show that what their risk over, say, a 20-year period was likely to be as a result of the trajectory that they've been put upon. So you have two groups. One group is the intervention arm, which has a lower risk, and a control group, which has a higher risk, and then you just model their trajectories, and then at the end of it, you measure the difference between the two groups. Microsimulation, I won't get into details because I actually don't do microsimulations, but it's much more complex. Oh, well, you can explain what a microsimulation model is. Too late. Anyway, it's quite a complex. There are people in my team that do microsimulation models. I suspect you guys probably won't need to do a microsimulation model, but you might be commissioning or working with people who do microsimulation. But it's essentially a much more complex, data-hungry form of economic evaluation that might generate more precise estimates around the effect. And it's based on simulating individual patients rather than an entire cohort as they go through different health states over a period of time. It does the same job. It ultimately enables you to so there are three jobs actually with modelling and economic evaluation. One is translation. So that's translating data that's been collected elsewhere from a different context, maybe with a population with a different background risk, and you translate that data to your population. So that's one role of modelling. The second role of modelling is extrapolating. So that's a time thing. So predicting what current outcomes are now in terms of, say, reductions in risk, and how that will pan out over a 20-year period in terms of reductions in events over a period of time. The third role of modelling is transforming outcomes. So you might have changes in risk factors now, but you want to transform that into QALYs and life years saved. So modelling enables you to do that. And these are all based on data from elsewhere. So you're not just relying on the data that you're collecting in a trial or the impact evaluation. You're now trawling through the literature to inform your model, to enable you to predict these longer term outcomes. And for a lot of prevention, so if you guys are involved in prevention, modelling is going to be a big part of the economic evaluations because you're not going to be collecting you're not going to see too many changes in QALYs over the lifetime of your study. What you need to see is a change in something that will then give you the signal that will enable you to model out. If you're not seeing any signal, then I would say that there's not much basis on which you can model improvement in outcomes. So there's in terms of modelled cost effectiveness, there are a number of advantages. It uses best available evidence rather than single study. So you're trawling through the literature, systematic review, meta-analyses, data. Enables the evaluation to be tailored to a policy question, so you're not tied to the study the trial, the design. So if your counterfactual in your trial is a do nothing or a placebo, but that's not really relevant in real life, as Verge said earlier. If standard care is the alternative, and standard care involves a whole lot of things, then you could potentially model that based on the evidence rather than just being stuck with the trial design that you were working with. And it enables you to assess the cost effectiveness at a population level. So what if this intervention was scaled up to a population level? What would be the cost effectiveness now? Again, that enables you to move beyond what you've encountered in the trial. Cons, and there are a number of cons in model cost effectiveness analyses. Relies on assumptions, relies on a lot of assumptions. As I said, when our experience with PBAC is that you often get models that are very hard to unpick, and the challenge there is also because it's an adversarial process. Is that there's an incentive on the people doing the modelling to come up with a certain result. So you're almost in a position where you're being challenged to have to find the problems in the analysis. And so, yeah, it's very difficult to work out, unpack these assumptions, particularly in very complex models. It's a black box assumption. Nonetheless, there's strong regulatory support for the use of modelled economic evaluations. PBAC, NICE basically mandate, or They have them in their guidelines and for use. So what kind of model? So ultimately, I suppose it's an obvious point. It needs to meet the needs of decision makers, but you also need to be pragmatic based on the data available, computational capacity and software. So in the Quartet study, what they did was look at change in blood pressure, which was the endpoint in the trial, and then modelled reductions in cardiovascular events and then ultimately QALYs. Here's the structure of the model. I won't go into too much detail because it's pretty sort of complicated, but the main thing is you can see here is it sort of breaks up into two branches. One is the intervention, one is the control. And the control essentially replicates what's in the intervention. So that squiggle here is basically saying that this is what we're doing. And it has this sort of framework where people can either go into a number of health states over a period of time. So you have a CVD event, or you die, or you have no event, and then you assign probabilities associated with each on an annual basis. And people cycle in and out of different health states and until you get to the 20-year timeframe. So that's a simple sort of explanation of the sort of model that they would have used. In terms of what they found, ultimately, it's interesting. If you look at the findings, quad pill versus irbesartan, which is, I guess, the standard treatment, there's not a hell of a lot of difference. It's a very small...
It's a blood pressure tablet.
Yeah, single blood pressure tablet. So there's just a very small difference in terms of mean total costs. So it's only about $200. And in terms of mean QALYs, it's very small. It's a 0.02 incremental QALY between the two, which is not surprising given the fairly marginal sort of trial-based findings. But nonetheless, based on fairly small sort of differences, we've come up with an ISA of $14,006. So on that basis, a probability of it being cost-effective at a cost-effectiveness threshold of $10,000 is 10%, but that's not really the cost-effectiveness threshold for Australia is around $50,000. So it's 100% chance of being cost-effective, a $14,000 threshold. I know Emily's not here, so it is a little sort of remarkable, the cost effectiveness turnaround with the modelling, and that was one of the things I sort of looked out for in the when I was on the PKC is how much the modelling affects, because you do have to present the trial-based results in an economic evaluation as well as the modelled. And it's almost like how much of this is modelling and how much of this is trial in terms of the final finding. And that sort of gives you a sense of, well, can I believe this? Anyway, it is what it is. This is cost-effective at $14,006 per quality gain. So impact. So for the quartet example, there's a few more hurdles to overcome before implementation because it's a pharmaceutical product. However, other types of interventions, example, changes in service delivery, can be implemented in local area health services quite quickly when there's a need and appetite for change. Okay, so that's it. Any questions or comments? Sorry, I didn't want to sound too down on Emily's work. She's not here to defend herself. She's probably got an explanation for some of the issues that I've raised.
Thanks so much. Look, apologies if I missed this in terms of. I presume it would be a good idea, so similar to like a research study where you typically, prior to doing the study, you put down your, what you are defining as significance, and you pre-register your trial so that you're not sort of trying to find that down the track. Unless I've missed that, I presume you're meant to do that, or it would be a good idea to be doing that prior to doing this analysis in the planning phase, where you're saying, I'm going to analyse it in this particular way rather than trying to analyse it in 50 different ways until you find something that looks pretty good.
Yeah, look, that's. I think that's the ideal. I think you saw in David's sort of guidelines, the cheers. Have you pre-specified an analysis plan for the economics? Unfortunately, it doesn't happen very often. I must admit, I'm a bit of a culprit there. The problem with modelling and with economic analysis is that you do have to be fairly sort of flexible because it is contingent on stuff that happens during the trial, which isn't always predictable. And your modelling strategy is also not just dependent on that, but dependent on what data you can pull out of the literature. So to be able to pre-specify a model, you have to be able to predict a lot of things reliably beforehand. And I would say that you're sort of setting yourself up for a bit of failure if you're going to be too rigid. I think with a trial, I can, 100%. I mean, it's standard practice, I guess, to pre-specify your protocol and your analysis plan. But with the economic analysis, because it follows on from the trial, and it depends a lot on what happens during the trial, I do think you need that flexibility to do things on the go. Oh, yeah. Shall we? Yeah, just roll on into the Q&A. Yeah.
Yeah. Thanks. When I look at the study, it's as if there's a small incremental quality benefit for a small incremental cost benefit. And so would you consider this study perhaps convincing, given that a small change in, say, drug prices, or maybe if they run the trial again with a different population, that could vanish? Because, I mean, even though there are confidence intervals or uncertainty intervals, there are also assumptions that the distribution of that uncertainty is a particular distribution, which may not be the case.
No, look, I think you're right. I think the fact that it's leveraging off a fairly small improvement in qualities does sort of raise a lot of uncertainty about it. But, again, there aren't that many interventions that give you a very sort of emphatic improvement in outcomes that you can then sort of leave it. I think a fairly small improvement is based with a fairly small improvement in cost is the norm, and it's the sort of uncertainty that we often have to work with in economic
So would that
evaluation.
be convincing enough, let's say, if you were going to judge whether you would implement this, would that be convincing enough?
I wouldn't just look at that number. I would look at a whole range of factors around the design of the study, the data and the modelling approach. So purely looking at that, the cost and quality and then the quality is one consideration. You might again go through that checklist and look at a whole range of other things to make a decision about that.
Sure, thanks.
Sorry.
These are questions. So we're going to have a kind of open panel and Q&A session now for all the speakers. David and Rebecca have gone. We're kind of running short on time, so we'll just make this an open Q&A.
Yeah. Yeah.
So that any questions and then any of the speakers can answer.
Yeah.
And I'd just say, so now we're only going to have one mic, so you've got to hold your breath for a couple of seconds till you get given the mic.
Yeah.
This is probably a really dumb question, but I was thinking about that idea of transforming. So you have the BMI and then you make an assumption from that. Just thinking about a project I'm involved in where we're looking at smoking cessation, but we don't have capacity to follow up to see if people stop smoking. We do have capacity to see if we hand out NRT, which is a treatment for smoking. So can you go from that? So we say we hand out 10 packs of NRT, so we assume that it has a certain effectiveness, and therefore we can work out.
Yeah.
Yes, it sounds very tenuous to me as I say it.
I mean, I think Richard might have more to add to this, but if there's evidence around NRT treatment that's fairly solid. But you still need to make assumptions about adherence and that sort of thing. Yeah. But if you can build that into your modelling, and I think the important thing is to be conservative.
Yeah.
You can make some conservative assumptions about adherence and treatment effect based on the evidence in the literature. Then you could probably come up with a fairly credible prediction of the impact on disease events and so forth.
What I would add to that is that we quite often want a final outcome that we're not going to be able to observe in our trials. So we have to rely on something like an intermediate or a surrogate outcome. And there's good guidance on how you might translate or use information on a surrogate to predict that final outcome, which then plugs into that modelled analysis that Steve's taken us through. So those guidelines come from statistics, they come from the biomedical world and then the health economics world, looking at, what evidence do we need on those intermediate outcomes to be able to have some confidence in our final estimate for that final outcome.
Thanks a lot. Hi, just a question on patient-reported data.
Yep.
If you're if you're looking at out-of-hospital costs for patients and they've got some kind of acute or chronic or, an illness that's significant, what would be the recommended way or an evidence-based method for collecting data that's reliable if you're wanting to know about their health or their utility costs and of out-of-hospital care?
So when you say out-of-hospital care, do you mean like primary care or...
No, so things that you can't collect data, so not primary care, things like...
medicines, those sorts of things.
Yes, or time off work,
okay.
carer responsibilities, bloody, blah.
Yeah, do you want me to...
Yeah, sure.
I'll start and then Virg, if you want to jump in, or Joe. So, time off work and productivity, there are validated tools to look at that, but you have to get the patients to complete them, the patient or the carer to complete them. The issue when we start looking at healthcare that's provided outside of the formal system, that's trickier. And the only way really to get at that is to ask people to do surveys that can get at that. Now, there might be some of that information. If you were able to get hold of a private health insurer's database, you could get some information about what they're using outside of the formal healthcare system, but again, that's challenging. So sticking with doing surveys that are looking at what's being used would be one way to go. There's a tool that comes out of the UK called the CSRI, the customer survey resource information questionnaire, I think is right. That's the right abbreviation for that. And that has a whole range of questions about healthcare use, covering the broad spectrum of what we might be interested in that is applied to patients or carers.
Thank you. Follow-up question. Where is there a time point, so you're talking before about collecting the data retrospectively versus prospectively, if they're acutely unwell, is there a way that you would go so that it preserves their, so it's, if they're very, very unwell, that it's hard to collect data, but if it's retrospective when they're feeling better, are they reliable?
What data are you talking about?
What kind?
Yeah, what kind of data are you talking about? Quality
the
of life?
The same,
cost,
but timing of collection of data.
Oh, okay.
Surveys, etc.
I think that's just
Do you want to?
pragmatic question.
Yeah, I mean, it's difficult. I mean, sometimes for our studies, quality of life is different, but we've collected data from family members, from people. It's not when it's not possible to actually ask a patient to collect that data or directly collect the data from them. I think that's.
It's a bit of a case-by-case thing. There's no pros and cons. You just got to work out what's best at the time.
There are lots of innovative ways of collecting data. Like Steve mentioned diaries before. I mean, in the settings that I work, we often use pictorial diaries for... we have illiterate, many people who unable to read or write, so we have designed many cost diaries that are pictorial for different... and there are resources. I mean, we can point you towards different resources for different types of diaries that are being used. So it can be difficult. I take the point.
But if they're still in hospital, you don't need to be collecting their cost data in terms of follow-up. That happens when you're following them up once they've left hospital. And, their representations or the use of GP services or allied health, that's where it becomes useful. If you're still in hospital 3 months, that's...
They're not in hospital.
They're not in hospital, no. Yeah.
I just wanted to make one point about the modelling. Could I get a sense how many people work in the area of infectious diseases, like as a primary area that you work in? Is it anyone? No. Anyone infectious diseases? Yeah, okay, all right. Well, I'll say it anyway. In terms of modelling, in the last decade, there's been a big move in dynamic transmission modelling. So this is sort of like a joint forces between the mathematicians and people like Ben up there who does a lot of modelling at the Kirby, and the economists working together. I mean, there's some economists that do it, but really it's the domain of the mathematicians. And it's really, really important for infectious diseases, because of transmission issues. Infectious diseases are different in terms of doing the modelling. And so when you're planning, I think the point I'm trying to make is that you have to kind of engage with those people as well. And often your health economists or the teams, they will have connections in that area, but it's a very important aspect when you're trying to do modelling, cost-effectiveness analysis for any infectious disease, whether it's you're looking at antimicrobial resistance or, I don't know, any infectious disease. Definitely do the dynamic modelling.
More questions? Anything that people were expecting to hear today that they didn't hear?
I just had a question about opportunity costs. So it seems like they could be extremely broad in terms of other applications that you could use for that money. Do you ever attempt to model these for comparison to an economic model that you're putting together, or is that just unfeasible?
Oh, who wants to take that one? So the breadth that you might go is really going to be determined by your question and who you're doing it for. So you don't want to go so broad that it just becomes nonsensical. What extent we go to doing it, that really again depends on where the situation that we're looking at. So I do a lot of work in the drug space, and we don't really try and go off and model opportunity cost, because most of the things that we're using have a very clear intervention and a very clear comparator. Most of the time they're already funded, or there's money available for them. So we don't need to think about looking at how else might this resource have been used. We're also operating within a very confined budget, which is the pharmaceutical budget. If you are operating in a broader budget, like capital service planners, for example, in New South Wales, operate in a much broader budget and asked to think more broadly about how a service might be provided in the hospital, out of the hospital, those sorts of things, then opportunity cost becomes quite relevant, and you need to think about, well, what are the options and the other ways I could use this money for, and what am I going to miss out on that's within my remit of effect? Anybody want to?
Yeah, look, I think in theory you want to look at across the economy what the potential opportunity cost of, say, $1 million invested in your program is versus defence, education, whatever. In reality, we don't do that. We recognise that the policy question isn't really about should I spend this on defence or should I spend this on this particular drug. It's usually this drug or the other drug, and therefore we have the benefit of a cost effectiveness threshold to determine whether it's cost effective. So that gives us the sort of benchmark for saying, well, this is value for money or not, rather than having to do this exhaustive sort of comparison about all the alternatives across the economy.
Other questions?
Here we go.
Hello. I was wondering, because today's focus is almost focused on economic estimation based on trials. Is it possible based on the data from observational studies? Because from my understanding, the previous section about the HIV paper, the only data they use from the trial is the risk reduction, is the proportion, and the risk action taking proportion. And so it's only these two things. I believe these two things could be retrieved from the observational study. So is it possible?
Yeah, look, I think you're right. And what the example that David shows is that ideally you have a treatment effect that's observed from a trial or from a systematic review of trials, because that gives you stronger evidence about the effect. But when you're modelling out things over a longer term time frame, trials very rarely give you that evidence, and you do have to rely on registry data or observational data to look at the long-term effects of, cholesterol lowering on cardiovascular risk or whatever. So usually it is a combination of trial data and observational data in your modelling.
Yes, I think there's a belief that the RCTs are giving the high-level evidence, if you can get that. But very regularly are we doing economic evaluations alongside real-time national rollouts of programs. So, colleagues of mine are currently doing an evaluation alongside the rollout of a national hepatitis C point-of-care testing program. Others are during the COVID, we did a national evaluation of the COVID point-of-care testing program. Obviously you're not going to and not take up those opportunities to do these evaluations alongside, national policy rollout. But I think that often, that you can't get away from the fact that the RCTs are often still perceived to be that high-level evidence, but it's not always appropriate or the only evidence available. Mm.
Just on the subject of evidence, somebody at the start of the day, I'm not quite sure who it was, commented about qualitative evidence being their field. Health economists are not devoid of using, are not averse to using qualitative evidence. In fact, I quite like it in certain ways. And when we're thinking about how we might construct these sorts of models and how we might think about evaluations, qualitative evidence and having discussions with people who are being affected by the interventions is really important in understanding what's happening to them, what matters to them, and then it also helps us put our results into context. So I think there was a question about, you know, the Cheers statement having two statements about patient engagement and patient involvement. That's the sort of area that we might use that sort of engagement and involvement within the confines of a economic evaluation like this. Of course, we do lots of patient work outside of that, particularly to understand preferences. But I didn't want everybody to walk away from today thinking health economics is only about numbers. It's not.
Well, I think what we're increasingly doing is doing an economic evaluation within the context of a trial, but also alongside a process evaluation. So the process evaluation will evaluate the implementation, the fidelity, of the study, and often uses qualitative evidence. And what we found when we're doing the economic evaluation alongside the process evaluation, it's actually helped inform the economic evaluation, particularly around the costing side. So understanding how an intervention works, who the actors are, what resources it uses, they're all information that are collected in a process evaluation through the process of interviews and qualitative analysis. So we then can use that information to more clearly sort of get a picture of what the resource use is. Otherwise, we just go, well, we assume it uses a lot of staff, we use this, but there might be a whole lot of hidden resources that they often get unpacked with the process evaluation.
Hi, thank you very much.
Oh, no, so just we've got one at the back.
Thank you. I haven't been in the health sector for very long. I came from other parts of public service. So in other parts of public service, we use cost-benefit analysis and audit analysis quite often in business case submission, evaluation, investment, and so on. But in health economics, how it's now being utilised, and in what occasions, how often, in grant application, for example, do we supposed to now, is that a mandate that we need to have health evaluation, or
It's not a mandate, but I think if you have a grant question that's amenable to doing some sort of economic evaluation, the assessors are going to look at it more favourably if you've thought about that. And if you have some idea or some write-up in your grant application about what you're going to do, and importantly that you've got the right people consulted to assist you in doing that. If you're a grant reviewer and you look at a list of who's doing the grant, and they're, health economics is core and central, and there's no health economist on there, the grant panel's kind of going to shake their head and, is this really going to work? So yes, it's not mandated in grants, but it is a good idea. I think, Steve, you talked about the fact that usually in health we do the cost-utility analysis, not cost-benefit. That is changing at a state level, particularly for the ministry, who has to follow the guidelines of Treasury, where everything is done using a cost-benefit analysis, or they require a cost-benefit. But at a national level, health very much is still focused on the cost-utility analysis because of that combination of length and quality of life, and also because of the challenges that both Joe and Rebecca alluded to with actually putting a monetary value on those outcomes. That's not an easy process. Sounds simple, and the Treasury guideline makes it look relatively straightforward, but it's not a simple process. You had it.
So I just wanted to circle back, if that's okay, to what you were saying about aligning your economic evaluation with the process evaluation, because I guess my impression was that you need to plan your economic evaluation at the beginning of the study, and of course the process evaluation is happening during implementation and looking at fidelity and reach and those sorts of things. So is it that you can start your economic evaluation but then input different things in as you're going along because they come up in the process evaluation? I'm not sure how that sequencing works.
Look, I think the process evaluation tells you what resourcing you should be trying to cost in your economic. So it gives you an understanding what actually is involved in running your intervention. So if it's a new care model, it tells you, these are the nurses deployed, these are the, this is the transport, the training, the materials, whatever. And it basically just gives you a template for costing. So it's not going to affect your ability to pre-specify doing an economic evaluation because they're the sorts of things you would have done anyway. It just gives you a bit more precision.
So I guess, really, because you can do your health economic evaluation once you've done your process evaluation and just say you're going to do it and give an idea of the sorts of things you're going to look at. I'm thinking about writing grants, right?
Yeah.
So you give an idea, you're going to do a health economic evaluation, talk about the broader areas you're going to look at, but you say that you're going to use a process evaluation to inform the exact costings, example, and aspects of that health economic evaluation.
And in a grant, you don't have to go into detail about everything that you're going to be costing. You can just say we're going to cost the intervention.
Yeah.
Look at the main items like staff, consumables, and equipment. Nobody's going to say, well, did you look at this? Did you look at that? That's it's not that interesting. They'll know you're going to be doing
I
that.
don't know, I've sat in grant panels, they're quite interesting. But you're right, not too much detail. I guess, I was just thinking about that sequence and, it's always good to pre-plan these things, right? So when you're thinking about doing an economic evaluation, you kind of want to know what you're going to do, and I find it interesting, the idea of using the process evaluation, which is obviously a great idea.
Yeah.
But think about how that works together is, good. Thank you.
Yeah, okay.
Okay, Steve, you mentioned at the beginning of the talk that sometimes politics and increasing awareness or consumer interest can drive certain, there's a greater preference for certain new technology. Would you factor that into models, or do you just leave this up to the minister and they decide?
Yeah, no, I wouldn't try to model that.
Yeah,
in a way, the economics is a response to that. Economics aims to give you a very transparent, evidence-based process. So it's almost like saying, well, we don't necessarily want to factor those things, and we're hoping politicians can not use politics to make their funding decisions. Here's an alternative based on evidence. Does that answer your question? Yeah, I wouldn't want to build that into the model. I don't even know how you could, but...
You might like to think... So if you had something where there was going to be a lot of... There was awareness and there was likely to be lots and lots of interest. I'm going to come back to an example I was talking to David about earlier, sildenafil, Viagra. You might in your model then say, well, if this is used by lots of people out there who don't have the primary condition of interest, are we still going to see the same effects? So in your sensitivity analysis, you might expand or adjust your treatment effect to say, well, actually, we know that this is less effective than in the trial if it's used in people who don't have that precise condition. How's that going to impact on our cost effectiveness? And that gives the authorities some information about, well, what might be that observed cost effectiveness? And is that something we're willing to pay for, or do we want to put some restrictions on who's going to get this service up front? They're blank.
Sounds like overload.
They're worn out.
I think it's been a great day. I think we're pretty much time's up anyway. We have to leave 15. But thanks for the day.